Assalamu alaikum. This is first of our lecture on series of lectures on thyroid disorders, and in this lecture we'll be talking briefly about thyroiditis, goiter, and solitary nodules. Most of the goiter and thyroid nodules are primarily dealt in surgical department, but of course the clinical status of that nodule, whether it is toxic or non-toxic, or whether it is functionally active or inactive, is a domain of a physician to determine. So we'll go through in a fashion like the case scenarios, and then followed by the workup which is needed in that. Our first case is a 28-year-old postgraduate resident in medicine who is seeking consultation for the complaint of low-grade fever which she is having for last 1 week, and this is associated with pain, particularly in the neck and throat region, and there is also a lot of body aches and pains. Along with this pain, throat, and fever, she has difficulty in swallowing and has noticed some hoarseness of her voice. There is swelling, and neck pain was initially on to the side, one side only, but then it had involved both sides of the neck, and there is slight prominence in front of the neck. Pain worsened on swallowing and coughing. On examination, she had a moist and warm skin. Her pulse was under 10 beats per minute. There was a firm, hard, tender swelling present on the anterior aspect of the neck with overlying erythema, and the lymph nodes were not enlarged. So with this acute onset of pain and a tender swelling in front of the neck, the differential diagnosis has to be possibly acute thyroiditis. Now, thyroiditis is actually a group of individual disorders which cause swelling of the thyroid, its inflammation, and then of course result in clinical manifestations which can be acute, which can be like the patient we described. Sometimes they can be subacute, and rarely, in fact more commonly, they may be presenting as chronic manifestations. So you talk of the thyroid gland and its inflammation. The one example we already had, that it can be an acute infection or inflammation of the thyroid. Sometimes it may be because of the drug. We will be talking about that drug-induced thyroiditis. Radiation to the head and neck area for other reasons can be responsible for inflammation and then thyroiditis. More common variety is an autoimmune, which is also called as Hashimoto's thyroiditis, and then there are group of disorders which may present in subacute fashion, and they are called as subacute thyroiditis. The acute infectious thyroiditis is though rare, but is not uncommon, and it can be because of the microbial inflammation causing suppurative thyroiditis, or sometimes it can be just inflammatory. The pyogenic or bacterial thyroiditis, though rare, is also seen. It's very rare out of the total group of thyroiditis, and in fact maybe not more than 0.1 to 0.7% of all the thyroiditis may be because of acute infectious thyroid. Usually this type of thyroiditis is more commonly seen in children or in pediatric age group, or adolescents, or relatively younger individuals of the age of 20 to 40. As we said, we are talking of acute thyroiditis of bacterial region. Then the Staph aureus and Staph pyogenes are the most common organisms, but fungi, mycobacteria, viral, they are not uncommon, and sometimes the infection may be reaching the thyroid from the pharyngeal or parapharyngeal tissues, and sometimes it may be persistence of thyroglossal remnants which are infected and then involve the thyroid. Rarely it can be an outcome of a previous surgical procedures on the thyroid, and repeated finite aspiration of thyroid can be a reason to introduce infection into it, and not to forget that the operative infection may sometime involve thyroid as well. And nowadays HIV is another common cause for acute thyroiditis. The symptoms, of course, would be of any infection in systemic illness with some constituent symptoms like malaise and fever and non-specific myalgias. The local symptoms are more important. Uh, of course, there is usually a painful enlargement of the thyroid gland. Because of this swelling, there may be some difficulty in swallowing or dysphagia. Some difficulty may be because of the say recurrent laryngeal nerve being compressed or esophagus being compressed, and some hoarseness of voice or dysphagia may be present. And sometimes it may be the pain which is causing it difficult to swallow, although compression is not that much. The signs and symptoms because of the thyroid dysfunction are either not there, or if they are there, they're very transient in nature. Sometimes there may be a transient hyperthyroidism, and on the other hand, sometimes it may be a transient hypothyroidism. Of course, that then returns to normal. Usually, the symptoms are self-limiting or short-lived, and as the infection is resolved, the symptoms of hyper or hypothyroidism, they are gone. The diagnostic workup of in patients suspected of having acute thyroiditis and infective thyroiditis should be, of course, the evidence of inflammation in the form of ESR. White cell count would be raised. T3, T4, TSH may be normal or may be abnormal. We'll be discussed in a moment. Thyroglobulin levels are usually elevated, but the most important physical, the lab finding is decreased radioiodine uptake. So when you assess the thyroid function, we usually do that, we ask the patient to have a measured dose of radioactive iodine to be taken orally, and this, if gland is functionally normal, would take up it either if the inflammation is much and is causing increased activity, the uptake would be increased. If it is normal, it would be in normal range, and if it is inflamed and is not taking up. Now, in acute thyroiditis, the radioactive iodine is not taken up by the glands because they are functionally not able to uh, concentrate or attract or move iodine into the cells. So that's the most diagnostic feature of this thyroiditis, reduced radioiodine uptake. If you go for an ultrasound of the neck, it may show an abscess or swelling in the thyroid region. Gallium scan is one which usually picks up the polymorphic nuclear cells, which are in signs of accumulation into the infected site. So the gallium scan would be positive. Barium swallow routinely is not indicated, but if you think that the infection might have reached from the gut through this periform sinus fistula or connection, then this barium swallow may be of help. In case of fine needle aspiration is indicated when you think that the abscess may be the focus of infection or collection of pus over there. Treatment is usually by antibiotics, or if you localize an abscess on ultrasound or respiration, that would require drainage. If you find a fistula, that fistula would be removed. And sometime if the infection is resistant to antibiotic, you might have to go for a partial lobectomy of the involved area of the thyroid, which is has formed into an abscess. The more common or more familiar form of thyroiditis is usually because of viral infection, rarely can be suppurative. As we noted, the presentation is through a tender thyroid with fever, malaise, and can have transient thyroid test abnormalities. If a patient is transiently hyperthyroid, sometimes it would require management by beta blockers, and mostly it is managed symptomatically. Our second case scenario is a 46-year-old female who presents in the outpatient department with complaint of painless midline neck swelling for the last 6 months. This swelling has been gradually increasing in size. During that last 6 months, she has lost her appetite. She is mostly constipated, also has some cold illness. Her mood remains low, and she feels generalized weakness and lethargy. The important thing is the family history. Her elder sister, one of her maternal cousin, and two nieces have been suffering from some thyroid disease. Now, this is a case scenario of a middle-aged woman who has not only has a swelling in front of neck, but also has some symptoms suggestive of maybe a thyroid dysfunction, or more in the form of a hypothyroid. But more importantly, there has been a family history of a similar disorder in other, say, cousin and maternal, say, niece and one of the aunt. What's the diagnosis? The diagnosis is Hashimoto's thyroiditis, right? And which is the more common form of thyroiditis or subacute or chronic thyroiditis, which is has a say inheritance pattern. It runs in the families, more particularly in the women. So Hashimoto thyroiditis is a chronic autoimmune type of thyroiditis. It is the commonest cause of primary hypothyroidism in the United States. Uh, since it is an autoimmune process, there are antibodies, and these antibodies are anti-thyroid antibodies, and more specifically anti-thyroid peroxidase or anti-TPO antibodies, which would be there in 90% of the cases, and rest of them may have anti-thyroid globulin antibodies. Sometimes this may immune process may lead on to atrophy of the thyroid gland, and spontaneous atrophic thyroiditis may be used as a terminology in those patients who have TSH receptor blocking antibodies, and some of them may have an anti-nuclear factor antibodies positive, particularly those who are younger than 20 years of age. They can be screened through this test. As noted that this affects mostly the young and middle-aged females. The incidence is almost 3 to 5 per 100,000 women. And if you compare it with the men incidence of Hashimoto's thyroid men is 0.8 per 1,000 men. Usually presents as a small diffuse form or rubbery swelling of the thyroid, or in the form of a goiter. And 25% of the patients usually are already developed hypothyroidism at the time of presentation. The treatment is just a periodic follow-up, since in the beginning they may be presenting as euthyroid or normal thyroid function, just swelling in front of the neck and with positive thyroid antibodies. But majority of them would develop hypothyroidism at some stage, and once they developed hypothyroidism, then of course the treatment in hypofunction of a gland in endocrine system is replacement. Now levothyroxine would be replacement therapy, and usual dose is 50 to 200 microgram, or maybe 0.05 to 0.2 milligram, and that dose has to be taken daily orally. Rarely we might have to go for surgical intervention if there are compressive symptoms there. Now, talking of subacute variety of thyroiditis, this usually again sometime is viral in origin, or sometime maybe again autoimmune. And again, this is a self-limiting type of thyroid condition. Usually, a patient goes through a triphasic clinical course. Initially, the transient inflammation leads to release of more thyroxine into the circulation, and patient presents with signs and symptoms of hyperthyroidism. But later, after some stage, the already formed thyroxine has all been released into circulation, and since the inflammatory thyroid cells are under the inflammation, do not produce further thyroxine, so the patient goes into a phase of hypothyroidism. And finally, there is return of normalcy to synthesize thyroxine, and the patient normally return to its normal thyroid function status. 15 to 20% of these patients presents with symptoms like thyrotoxicosis, and 10% of the patient present with hypothyroidism. The common recognized forms of subacute thyroiditis include the subacute granulomatous painful thyroiditis, which is also called DeQuervain thyroiditis. There is a variety where there is a lymphocytic infiltration into thyroid tissue, and this then presents as a lymphocytic thyroiditis, also known as subacute painless thyroiditis. And then, in the same note, subacute postpartum thyroiditis is also uh, a recognized entity. The DeQuervain thyroiditis is usually self-limited, mostly due to viruses like Coxsackie, mumps, or adenoviruses. The gland is mostly enlarged, it's painful and tender. Initial phase of thyrotoxicosis lasts for 4 to 6 weeks, and this, as we said, is due to increased release of already stored, say, thyroxine, which has already been preformed in the colloid due to inflammation. This then is followed by a period of hypothyroidism, which lasts again 4 to 6 months as stores are depleted, and follicles then recover, and the euthyroid state ensures and patient. So this is what we call as a triphasic form of presentation. In this triphasic phase, the total say length of this phase may be few months to maybe a year or so. The diagnosis is made through the evidence of inflammation in the form of raised DSR. Sometimes they may have a normocytic normochromic anemia along with that. TSH is mostly low and elevated T3, T4 in a stage of hyperthyroidism. Antithyroid peroxidase and antithyroglobulin antibodies, if detected, have very low titer, and as we already mentioned, that the inflamed thyroid follicles cannot take up radioactive iodine, so radioactive iodine uptake is low. The treatment of this condition is usually anti-inflammatories like NSAIDs or salicylates. Oral steroids may be of help, and this prednisolone in the dose of 40 milligram daily for 3 to 4 weeks may be given. Patients with symptoms of hyperthyroidism or with tachycardia and say may be benefited by use of beta blockers. Apanic acid may be used for more severe symptoms. Symptoms may require repeat course of steroids or anti-inflammatories, and sometimes this subacute thyroiditis may again uh, either transform into, or the patients may later develop Graves' disease as well. Lymphocytic thyroiditis is usually self-limited. It is usually caused by antithyroid antibodies or autoimmune diseases, and clinical features again are thyrotoxicosis followed by hypothyroidism. Our third case is a 27-year-old lady who delivered a live healthy baby 3 months ago, and now 3 months down the lane she presents with restlessness, palpitation, fatigue. She has lost about 3 kg weight over last 1 month. On examination, she is an anxious looking young lady with a pulse of 100 beats per minute and a blood pressure of 110/70. On neck examination, a mild diffuse non-tender goiter is noticed, and the lab shows raised T4 but low TSH. So, what's the diagnosis? The diagnosis is postpartum thyroiditis. Postpartum thyroiditis is usually occurs in women after birth of the baby or after delivery. It again has two phases. The initial phase during 1 to 4 months after delivery is an overactive phase where the patient presents with symptoms like hyperthyroidism, and this is then followed by 3 to 8 months of underactive phase where the symptoms of hypothyroidism predominate, and then these patients mostly return to normal euthyroid state. Sometime it may be that the patient was actually hyperthyroid and was masked and was not previously recognized, and only during pregnancy the subclinical autoimmune thyroiditis has become to light, and the patient are showing symptoms only during pregnancy. The antithyroid antibodies may be positive in early pregnancy. Negligible radioiodine uptake would be seen on thyroid scan, and this again, this postpartum thyroiditis has a tendency to recur in subsequent pregnancies. So each time when these ladies become pregnant, their thyroid function has to be monitored uh, post prepartum and during the say antenatal workup and during pregnancy. But most of these women who develop postpartum thyroiditis at some stage during their pregnancies are likely to proceed to permanent hypothyroidism eventually. So that's why that these ladies are definitely to be followed up even after pregnancy and later in their life as well. Riedel thyroiditis is more likely a surgical type of a condition where the gland undergoes a lot of fibrosis. Thyroid antibodies though present, but the most important thing is the painless goiter, which is body. This is actually the term when this patient underwent surgical removal of the thyroid gland, and when these thyroid tissues which are obtained after removal were cut down, the cutting effect was more like a gritty sensation or a woody sensation. So that's why, and that is because of the gland has undergone a lot of fibrosis. Pre say surgical or preoperative diagnosis should be confirmed by a biopsy, and this may be associated with the fibrosis at other sites, and this may be called as a focal secretory syndrome. Sometimes there may be a retroperitoneal fibrosis associated with that. These patients may have some mediastinal or retroorbital fibrosis or sclerosing cholangitis. So there is an increased tendency of having fibrosis of other non-thyroidal tissues or areas as well, and this should be searched for. Treatment, of course, would be resection, particularly if the fibrotic gland is causing compression symptoms or is involving the recurrent laryngeal nerve or adjacent tissues. Chemotherapy with tamoxifen and methotrexate or steroids has been found to be effective, and if they develop frank hypothyroidism, the thyroid hormone replacement therapy would be required. Our fourth case scenario is a 65-year-old male who presents with unexplained weight loss of about 7 kg over the last 6 months. He also has palpitation and has increased sweating. He suffered a transient ischemic attack 4 years ago, and at that time he was diagnosed to have low atrial fibrillation. Patient was put on amiodarone for the treatment of this atrial fibrillation, and along with that he's taking aspirin, and also was put on anticoagulant warfarin 7.5 milligram OD to prevent the development of a embolism resulting from a atrial fibrillation. His ECG shows atrial fibrillation, and he on thyroid function testing he had elevated T3 T4 with the undetectable TSH. So now this is again a patient. If you think of someone at the 65 developing atrial fibrillation without any known underlying cardiac illness, either valvular or ischemic, the one of the diagnoses of someone developing atrial fibrillation is to consider hyperthyroidism or occult form of a thyrotoxicosis. But since this our patient was already had a manifest cardiovascular disease in the form of a TIA and was put on medication, and he developed, say, atrial fibrillation, and for that he was put on amiodarone. Now, this is a case scenario where you can think of a lone atrial fibrillation because of an underlying thyroid disease, or this thyroid disease might have been precipitated by use of amiodarone. Right. So amiodarone is one drug which can cause thyroid dysfunction. If you look at it, the name of the amiodarone, there is a lot of, this is an iodine containing drug. It has a lot of iodine, and of course the whole of the thyroid function revolves around iodine and its uptake by the gland, and this iodine being say used to manufacture or to make uh, thyroxine. Now, this is an example of drug-induced thyroiditis. The drugs which are notorious to cause that, amiodarone is the one of the top listed drug which can cause thyroid dysfunction. Lithium is an antidepressant. Again, it interferes with the say iodine uptake and can be a reason for thyroid dysfunction. Interferons previously used for mostly for the treatment of hepatitis C and B. They are they were a reason for developing hypothyroidism in patients who were treated with interferon for hepatitis C, and of course cytokines and so many other things can be responsible for. The clinical features of a drug-induced thyroiditis may be either thyrotoxicosis or then maybe later as in hypothyroidism. Usually the symptoms continue till the drug is being used, and once this drug is withdrawn, mostly the patient dissolve, except for interferons where even after the withdrawal of drug, majority of the patient remained hypothyroid despite the drugs being withdrawn from the treatment. A note about this amiodarone-induced thyroiditis, as we said, the amiodarone is this, in its name you have iodine into it. So amiodarone has structural analogy to, its structure is similar to thyroxine or T4. Now, one 200 milligram of tablet of amiodarone contains around 75 milligram of iodine. Now, this is quite a high dose of iodine. Normal daily requirement of iodine in individuals is around 125 microgram. And look at it. The normal requirement is 125 microgram, and those who are using amiodarone for treatment of their arrhythmias, they are having 75 milligram in each of their dose. So this high dose of iodine does have a cytotoxic effect onto the thyroid follicles. So 20% of those who take amiodarone will develop either hypothyroidism or thyrotoxicosis. Right? Hypothyroidism, because again when you increase the substrate, the receptors for uptake, they get down regulated, and there is not further uptake of iodine is blocked, and the patient developed hypothyroidism. But the thyrotoxicosis, which develops as a result of amiodarone, again can be classified into type 1 or type 2. The type 1 is iodine-induced excess hormone synthesis, which usually is treated with antithyroid drugs. But type 2 is an induction of a thyroiditis because of the cytotoxic effect of the amiodarone, and this might be requiring steroids as a form of treatment. Another important thing of amiodarone or this drug is that it's a very long half-life, 50 to 60 days. So even if you withdraw this drug, it would take around 2 months or so to have these effects gone, and this patient again may remain symptomatic even after withdrawal for about 2 months. Those who developed symptoms of hypothyroidism would require levothyroxine, and those who develop symptoms of hyperthyroidism and initial thyroiditis may have to be treated with steroids. Radiation, we did mention that the radiation to the neck area may lead on to dysfunction of the thyroid follicles, and this may result in hypothyroidism, or initially mm, those patients who are treated with radioactive iodine usually is given in the form of ingestion, again would have a transient phase of hyperthyroidism. And those who undergo external beam radiation for treatment of cancers, they likely to have the gland being destroyed by the radiation, and patient may develop symptoms of hypothyroidism. Occasionally, these radiation-induced thyroiditis is thyrotoxic in nature or hyperthyroidism, but most frequently it is hypothyroidism, which is the manifestation of radiation-induced thyroiditis. So, in thyrotoxic thyroiditis, the phase of thyrotoxicosis is usually transient, and in majority of the cases, they developed hypothyroidism, and this hypothyroid state is usually permanent, and it requires uh, lifelong thyroxine replacement. Next, we go on to the goiter. Now, in thyroiditis, in many of these patients, you may have a clinically impalpable thyroid gland. In Hashimoto's, you do have gland swelling, but in drug-induced thyroiditis, or in say say autoimmune thyroiditis, the gland usually is not enlarged. Now, goiter is a condition, it's just a term used for when you have an visibly enlarged thyroid gland, or it is causing a swelling in front of the neck, and this is called as goiter, or in local language it is also called as giller. When you have someone on examination that the thyroid gland is palpable and is enlarged, you call it as goiter. Now, these goiters can be of four types. It can be a simple goiter, which is, as we mentioned, there is be no hormonal abnormalities, no systemic effects, and it just would be a palpable thyroid gland, which may result from sometime iodine deficiency, and sometime maybe a physiologic requirement being increased, like in puberty or maybe during pregnancy. But important is to note that this gland or goiter has, along with it, toxic effect, or the features of hyperthyroidism. Now, some of these goiters may be leading on to an increased production of thyroid hormones, and these may present with hyperthyroidism like Graves' disease. We'll discuss in more detail in coming lectures. And there may be either a single nodule which has undergone toxic change, or it might have gone multiple nodules which sometimes become overfunctional and present as toxic. So important is that when you have a goiter, whether it is a simple goiter, euthyroid, probably just a cosmetically enlarged thyroid which may need attention, or this goiter is because of um, causing hyperthyroidism or causing function. But another thing is that possibly, isn't it, maybe neoplastic. Now, this neoplastic, again, this neoplastic thyroid gland may be just benign adenoma, or maybe a malignant, right? And finally, we already have discussed previously the thyroiditis, that many of the thyroiditis may present like in subacute Granulomatous or Hashimoto's, as an enlarged thyroid gland, and sometimes acute suppurative thyroiditis may have an enlargement. So the four possibilities of a patient with a goiter may be a simple physiologic goiter, maybe it has undergone toxic change, or maybe neoplastic, or maybe inflammatory. So how do we proceed about that? The simple goiter is, as I said, mostly because of the iodine deficiency areas, in those areas where the iodine, like hilly area in Pakistan. It is because of the heterogeneous response, because there is iodine deficiency, there would be less synthesis of thyroxine, and this would lead on to feedback response from the pituitary to increase TSH. Now TSH would lead on to stimulation of thyroid tissue to hypertrophy. And this hypertrophy response of the gland to TSH may be variable. Some areas respond well and some areas do not respond. Those which respond well develop a nodular change and develop a nodule. Now this is the reason for multinodular goiter, because of chronic stimulation and heterogeneous response of the thyroid tissue to the thyroid stimulating hormone. Those area which has iodine deficiency, there maybe have a growth potential under the influence of TSH, and this 30% of the patients, more than 30% of the patients may show a multinodular goiter as a result of uh, iodine deficiency alone. When you evaluate their thyroid function, you check for their thyroid stimulating hormone T3 and T4, and you may come across either patient as overt hyperthyroidism with sign and symptoms of thyroid with a low TSH and raised T3 T4. But majority of the patient may have a subclinical form of hyperthyroidism, that their TSH may be low and their T3 and T4 may be normal. Now this is the situation. In the initial situation we said there may be a deficiency, there may be an increased TSH, and this TSH is in response to low T3 T4 and the body is unable to compensate. But sometimes this chronic TSH mediated stimulation make those glands autonomous. They lose their effect from the TSH and they start producing sufficient or more T3 T4, and this then results in TSH being suppressed, because since the gland has become now lost its control as a result of TSH. So in patients with goiter, it is important that we determine that what is the thyroid status, whether patient is in a hyperthyroid stage or is in a hypothyroid stage, because that will determine our course of say medication or management. So in simple goiters, colloid goiter, usually a mild enlargement of the gland. Patients are mostly asymptomatic and they are mostly euthyroid. Incidentally, this is again more commonly seen in women in third to fifth decade of their life. It rarely have complications like as a result of a mass effect, which is compressing trachea or compressing rectal nerve, and may cause some dysphonia or dysphagia or difficulty in swallowing. Rarely, this simple goiter may have some an acute development in the form of that they may develop hemorrhage into a nodule or into a cyst, and this then gland becomes maybe acutely painful and tender and all the features of inflammation. So this is what we have to look for, that whether the patient is euthyroid or not, and whether there are any compressive symptoms or is there any acute development happening into it. The investigation in these cases would be, of course, doing their thyroid function test, performing a neck or chest X-ray, and sometimes CT scan of the neck and chest may be required to locate for any retrosternal extent or any uh, regional lymphadenopathy. Ultrasound neck would help us in defining that whether it's a diffuse enlarged gland or nodule, or is there any cyst. Isotope scan will tell us about the radioiodine uptake status of the glands. A gland in a hypothyroid state usually would have a decreased uptake, and a hyperthyroid state may have an increased iodine uptake. And then rarely the fine needle aspiration is required to look for that whether this is just a benign inflammation or just a follicular hypertrophy, or rarely that this gland might not have undergone a malignant change and developed a malignancy. This is just to show that how the thyroid scan or iodine uptake scan appears on. So if you concentrate on this in normal gland, the the amount of iodine taken up by the gland is reflected by these grayish or blackish spots. So normal gland has two lobes, and this is the usual pattern of uptake. The patients who have this Graves' disease leads on to an increased uptake of the thyroid, because thyroid is concentrating the iodine into manufacture more thyroxine. So compared to this uptake is increased, and it is shown up as more dense blackish or grayish areas. Now, when you talk of say multinodular goiter, now this gland is normal gland. Now this gland shows multiple nodule, one over here, another one over here, another over here, and again. If you look at the density of the uptake, the sum of the nodules, they do show a markedly increased uptake, and the rest of the gland shows. Now this is the gland, the nodule, which has undergone possibly a toxic change and has started accumulating more of iodine, and these nodules may be now producing more thyroxine. The patient may have symptoms of hyperthyroidism as a result of increased synthesis because of this toxic. Sometimes you may have a single say area of the gland which is taking this iodine concentration more, and this results in localized area of increased uptake, and rest of the gland does not show as say clearly defined uptake. Now this is a toxic adenoma. Now these are the 3 or 4 patterns which you can see on an isotope scanning of the thyroid gland. A normal gland diffusely taking thyroid iodine. Graves' disease symmetrically increased, and some enlarged gland as well. Multiple adenomas, toxic nodule, sorry, and then this is a single adenoma. The prevention of this say goiter, a simple goiter or colloid goiter, is that do treat the iodine deficiency if that is the cause, and this is done through the iodinization of the salt, the table salt, which is the nowadays even in Pakistan most of the salt available is iodinized. In patients who develop symptoms of hypothyroidism, or who have markedly elevated TSH, and this TSH is then responsible for further hypertrophy. This TSH can be suppressed through exogenous administration of thyroxine. Rarely you would require a, say lobectomy or thyroidectomy for both, either because of the toxic symptoms or because of the compressive symptoms or maybe cosmetic reasons. Some of the individuals may have a single solitary nodule impalpable. Most of the time this is they present in surgical OPD, and this usually the picture that you probably have with just a visible nodule, and when you palpate you find that this is a mobile swelling with the swelling moving with the deglutition, so it's possibly within the thyroid gland, and this may seek patient may seek advice for that. The essential clinical problem when we find this type of lesion is that whether it is a benign or a malignant nodule. So that is the most important question in a single isolated nodule in the thyroid. This is how we define that this is say solitary nodule dominant, and if you perform an ultrasound examination, it would be normal gland. This is the lobe of, this is trachea and the right lobe of thyroid, and this is you find a very dense and hyperechoic type of area, hypoechoic type of area, which is possibly a nodule. The solitary thyroid nodules are majority of them are benign. They usually be called as colloid nodule. They may have Hashimoto's thyroiditis sometimes may have nodules. We did talk about the cyst in the thyroid, which may be simple or hemorrhagic cyst. We did talk about a follicular adenoma presenting, and then of course some type of subacute thyroiditis may present as a solitary thyroid nodule. But more importantly, we have to look for that the solitary thyroid nodule may not be malignant. Now, the malignancies can be the primary malignancies of the thyroid, which may be arising from the follicular cell, and these the two or three types of the malignancies of the thyroid rising from the follicle can be called as papillary thyroid carcinoma or follicular thyroid carcinoma, and sometimes it is called as anaplastic thyroid carcinoma. And then of course there are say this C cell into the thyroid which produce calcitonin. The C cell mediated uh, carcinomas may be in the form of medullary thyroid carcinoma or a thyroid lymphoma. Now these all can be considered as right primary say thyroid malignancies. Rarely, there can be metastatic disease to the thyroid gland as well. Now, this is a summary of an approach to a patient with a thyroid nodule. If you find a patient who has a thyroid nodule, the first thing to do is that you do his or her TSH test. Whether this TSH is normal and suggests a euthyroid state, or TSH is an abnormal and suggests a thyrotoxic state. Right? So low TSH would be thyrotoxic and normal TSH would be euthyroid. So we take on this pathway, this euthyroid nodule would go for a fine needle aspiration, and the fine needle aspiration may give you four possibilities that this is a benign type of tissue, and all you need is that observe, or sometime as we said that we may give thyroxine for about 6 to 12 months to suppress the TSH, and then the ensuing or resulting say nodule being suppressed. If this final respiration becomes suspicious that there are anaplastic cell, there are Riedel cell, there are so this would require a surgical intervention. If it turns out to be malignant, again the answer is surgery, and if it is turned out to be the inadequate, of course repeat FNSE has to be performed for that. But if your initial TSH evaluation of a thyroid nodule suggests of thyrotoxic state, where T3, T4s are increased and TSH is low, you then perform a thyroid scan. Now this thyroid scan, if it turns out to be a cold nodule, right, cold nodule usually is likely to be malignant, then you have to undertake fine needle aspiration of this cold nodule. But if this thyroid scan suggests a hot nodule mean that this patient possibly is having a toxic nodule. So there are two options. Either you treat this toxic nodule through a radioactive iodine orally, or you may go for surgery or for the removal of that toxic nodule. This is just to show that a cold nodule would be appearing as that area which does not take iodine, while the rest of the gland is taking iodine very normally and is becoming this dense shadowing. And a hot nodule would be that the nodule only is taking the iodine and it has suppressed rest of the glands to an extent that it appears as if the iodine is not taken up because all the iodine is being concentrated into the nodule. So this is the difference between a cold nodule and a hot nodule images. These patients who present with multinodular goiter or a solitary nodule must be undertaking CT scan of their neck and chest region, because most of the gland may be retrosternal or maybe into the extending into the mediastinum. This is an example of a patient who had a hugely enlarged thyroid swelling which is pushing the trachea to the right, and you can see multiple areas of say density in this gland. So this is an image which shows a very large asymmetric multinodular goiter, right, which is pushing the trachea to this side. And then this CT scan of this patient confirms that there is a large retrosternal goiter, and which is pressing the trachea to the opposite side. The other images which can be used in these patients could be PET scan or positron emission tomography, and this of course would give you a three-dimensional picture reconstruction of the images. And it also would be helpful that this, if there is a thyroid tissue present in other areas other than thyroid gland, or it has metastasized, so it would show or outline those not only the primary site of this tumor, but the metastasis to the other body tissues. Usually PET scan in preoperative thyroid tissue is done to differentiate the benign and malignant lesions, and whether it should be done preoperatively is controversial, but definitely post-operative follow-up in these patients would require that if they still remain symptomatic, then there is some thyroid tissue, residual thyroid tissue present somewhere in the body, and this PET scan might detect it. Ultrasound guided FNAC, of course, is usually indicated for palpation guided FNAC. If it is not, say, has a low yield, so in patient with this ultrasound guided FNAC would be more appropriate. Those who have a solid or cystic nodule, the FNAC is required. When you have a palpable nodule, which is usually less than 1 per centimeter, you do biopsy under, say, ultrasound control. And of course, if there are abnormal cervical nodes or who have ultrasound feature which is suggestive of suspicious nodule, you go for ultrasound guided final aspiration. Suspicious cytology would mean that the patient either has a follicular neoplasm or dorsal neoplasm, or there is a typical, say, parathyroid, this PTC or lymphoma. The treatment of nodule, hormone administration has very little evidence to affect the benign nodules. Surgery indications usually include either a patient with suspicious or definite FNAC, and if continue enlargement despite TSA suppression is there, the surgical intervention would be required. If the patient has mechanical symptoms, and sometimes maybe just because the cosmetic reason that it doesn't look nice to have say huge thyroid swelling, particularly in women in younger age group, the cosmetic reason for surgery may be indicated. So that's all for today. We have covered the various forms of thyroiditis, and out of these thyroiditis, we did talk about that the autoimmune type of thyroiditis and postpartum or peripartum thyroiditis is more important to be note. And when you have a nodule, this nodule needs to have a workup for whether this is simple nodule, patient is euthyroid, or this is a benign nodule or a malignant nodule or a toxic nodule, and the approach would depend upon what type of this swelling is. Thank you for your say patient listening. Thank you very much.